Welcome. My name's Steve Scanlon. I'm from the Sociology and Anthropology Department. And today I have the pleasure of introducing Dr. Elizabeth Beverly, who's here to do our talk titled Comprehensive Patient Navigator Program for Rural Appalachia. And I just met Liz 2 minutes ago, I guess. But I'm looking forward to her talk. The topic is going to be very exciting, very important with regard to rural health and the work that both she and OUHCOM is doing in the region and beyond. Just a bit of a biography, and then we'll go ahead and turn it over to Dr. Beverly. Dr. Elizabeth Beverly is an assistant professor in the Department of Family Medicine at Ohio University's Heritage College of Osteopathic Medicine. She graduated from Penn State University with a Bachelor of Science degree in 2003 and with a Doctor of Philosophy degree in Biology and Behavioral Health with a minor in Gerontology in 2008. She recently completed a 5-year postdoc fellowship in diabetes at Harvard Medical School with the Joslin Diabetes Center. So we're very fortunate to have her in our midst now. Dr. Beverly's research in diabetes and behavioral medicine examines the behavioral and psychosocial challenges that arise from following diabetes self-care recommendations and treatment prescriptions. She regularly participates in research integrating both quantitative and qualitative methods to better understand the management of both type 1 and type 2 diabetes. More specifically, her research addresses individual patient characteristics and abilities necessary to 1, follow treatment recommendations, 2, improve self-care, and 3, maintain improvements in diabetes self-care and glycemic control. So with that, please join me in welcoming Dr. Elizabeth Beverly.
Thank you all. I apologize. I ran literally from the med school, and I have proof because my office colleague, I ran ahead of her so that I didn't realize you were coming, but she's here, so she saw me running. So thank you for having me here. Thanks for the wonderful introduction. I really appreciate it. So just what I do is I do research. I'm not a physician. I'm in a department with physicians, but I do research, and I do a lot of collaboration with physicians, and I'm going to talk about diabetes because it's really, really relevant here, and it's really relevant as it relates to poverty. So how many people here know someone with diabetes? Okay, that's what I was hoping for. So what is our background in terms of education? Do we have a lot of sociology, anthropology, public health? Okay.
Social work.
Social work. You guys are the most important people. So in my dream, after I achieve tenure, which hopefully that happens, I want to go back and get a social work degree or nursing so that I can, and you'll see, because I want to be a certified diabetes educator. And you can't be a certified diabetes educator without some form of a clinical degree. So I can get all the education I want, but if I don't have the right degree, I can't be a diabetes educator. And I think that's what we really need in this region. So before I start, I have no conflicts of interest. I will be presenting some data from a funded grant that the med school has right now. It's from the Health Resources and Service Administration, HRSA. Have you guys heard of HRSA? Yeah, so HRSA is really important, and the great thing about HRSA is they fund programs and programmatic research in this region. And so a lot of the initiatives that we can do to help the rural population as well as focusing on health. So for the future social workers, look at HRSA funding because they will, if you're willing to stick around in this region or to other rural areas, they will provide funding, which is excellent. So I'm just going to give a little bit of background on diabetes. I didn't hear anybody say that they were like a biology major or pre-med, right? No? So I'm going to make it very simple and very basic to understand, but to me it's really important that you have a little bit of an understanding what diabetes is so you can see why it plays so much into rural health as well as into poverty. Then I'm going to talk about this new initiative that we have that we've been running the program for a year, so we don't have all the data that we would need. We still have 2 more years to complete from the grant. But I'm going to talk about the novel program and why it might be so important to address poverty in this region. And then some of the clinical lessons, because again, the study isn't finished. So I only have data from year 1 of the study. But we've learned a lot clinically from this, which would be very meaningful. And in fact, it might be most helpful to the public health and the social work students and faculty. So we know we're in Appalachia, right? Okay, we know that it's over 200,000 square miles. Okay, 13 states from New York to Mississippi, right? I'm going to be focusing on southeastern Ohio. Okay, so I'm going to be focusing on these counties here, all right? And I'm going to talk about it in terms of rural health, poverty from this region, as well as diabetes, okay? everybody here knows someone with diabetes, right? I have family members who have diabetes, and my best friend has type 1 diabetes. So I'm very passionate about this topic because it hit close to home. And it sounds like everyone in here might have a touch with this as well, and maybe some of you might go into future careers where you're going to be working with diabetes patients. And it's an issue that we need to focus on because, as you can see here from some of the most recent data from the CDC, 9.3% of the US population has diabetes, okay? That's 29 million people. And I can tell you that this data isn't even up to date right now because that's how it works when you collect data. It takes so long to collect it and then analyze it. By the time you actually present it, you're 2 or 3 years out of date. I think the rates are much higher because who here does research? Right? So what are some of the problems with doing research? Do you always get everybody that you want to participate in the study? No, right? And what are some of the big barriers to a region like this to get people to do research? They might not want to do research. They don't want to be used, right? But a lot of the data we get comes from telephone surveys. So right away, you should automatically think, well, there's bias right there because you have to have a telephone or you have to have permanent housing. So we aren't even getting correct estimates for diabetes, which is why it's not only an epidemic, but it's even bigger epidemic than we realize. And then the stat that I don't even have here is prediabetes. So we have about 330 million people in the United States. 86 million are estimated to have prediabetes. So just so you know, I have prediabetes, and I literally ran here. So I'm trying to exercise and get as many steps as possible, but I still have prediabetes, and that's because I have a family history of diabetes. All right, so 86 million people have prediabetes. That's about a quarter of the US population. So if we were to say this is the US population, a quarter of us right now have prediabetes. And that means we're at much greater risk of having diabetes later in life, okay? And that's so important because diabetes, do you guys know a lot about diabetes? Anyone feel confident enough that if I had to ask you what is diabetes, you could give me a little bit of an explanation for what it is? It's so important because it affects every part of our body. So anyone who's going to go into social work, psychology, anthropology, public health especially, anyone in medicine, it affects everything. There's no one who's going to become a health professional and not have a patient with diabetes or not have a patient who's affected by diabetes because it affects every system, including someone's quality of life and their mental health, which is why it's so important. So just a little bit of background, okay, and I'll try not to bore you, but diabetes is a group of diseases that's marked by having high blood glucose levels. Okay, so most of the times people refer to it as blood sugar, okay, or I have the sugar is very commonly referred to. Type 1 diabetes is where the individual, so who ate lunch today and who's eating right now, right? Some of you guys are taking snacks right now. So we take our food that we eat and our body is amazing, right? And does these amazing things that we don't even realize. And one of the amazing things we do is we take the food we just ate and we convert it to glucose, okay? And glucose is important because we have a lot of cells in our body and that's the basic fuel for cells. I always make the analogy, it's like if you want to drive your car, you need gas. If we want to function properly, we need glucose in our cells because it's the fuel for us to do our actions. So we just took whatever snacks you had or whatever you had for lunch, we converted that, our bodies converted that to glucose. And it's amazing because it did it and we didn't have to do anything, right? It was very easy. And what happens when you convert it to glucose, automatically it sends a signal in your body for your pancreas to release insulin, okay? And what insulin does, it allows us to open the cellular door, as if we actually had doors, and put the glucose inside the cell so that the cell can use it for energy. The problem is with diabetes, you either have a problem with making insulin or not having enough insulin or you're not using it properly. So with type 1 in general, we say there's a problem with not making enough insulin for your body or not making insulin. So that means your cells aren't getting glucose. For type 2, it's either you're not using insulin properly or you're not making enough insulin or it's a combination. So as mentioned in the introduction, I did my training. I was very lucky to do 5 years of training in diabetes at the Joslin Diabetes Center. And it's famous because it's the first diabetes center ever created. And so that's why it's famous. And it also helps to say that you're affiliated with Harvard, right? So these are some of the images that Joslin uses to do education. So this is insulin. It's the letter I, right? Very nice and easy to understand. So we just ate. We just started converting our food that we consume to glucose. It signals our pancreas to release insulin. Insulin says, hey, I have the key. I'm going to open the cellular door and let the glucose in so that the cells can have their energy. If you have type 1 diabetes, you don't have insulin, which means you don't have the key to open the door. So what happens is, in your bloodstream, the glucose just hangs out. And that's why you have high blood glucose levels, okay? And then for type 2, it's either a combination of the insulin's just not working properly. So you see here, they use the insulin's really struggling to open that door, okay? So you still have high glucose in the bloodstream. So you still have the high blood glucose levels. Maybe some's getting into the cell, okay? But you still have a lot left over. So it's either a function of not making enough insulin or the insulin in your body's not responding properly. Just to give a little background information for patients with diabetes, okay, and they do this based off of diagnosis. So I said that I have prediabetes. Most of my family members have prediabetes if they don't already have diabetes. And that's all based off of this A1C. Hemoglobin A1C. Has anyone ever heard of that before? So that's just the way that we measure someone's blood glucose level. Because right now, we don't have the perfect measures in our body. Because medicine, even though we make it sound like we know a lot, we don't know as much as we should, right? And right now, it's the best measure we have for someone's average blood glucose level, okay? And what we want for that is, we want a person who has diabetes to have an A1C less than 7%, okay? And I'll show you in a minute what that means. And then you guys hear people taking their sugars or taking blood glucose checking. You check, and these are what some of the goals are laid out by their providers, okay? This is my way of understanding things. I'm a kind of a visual person. I like to understand this. So hemoglobin is a part of a red blood cell, right? We're full of red blood cells. Hemoglobin is really important because it carries oxygen, and we need oxygen to live. Well, it also turns out that hemoglobin loves glucose. So glucose just binds to your hemoglobin. And that's why we use it as a measure for someone's average blood glucose level. So you can see here, for those who are in the non-diabetes range, your A1C will be between 4 and 5.7%. Those who are in the pre-diabetes range, it'll look more like this, okay? And those who have a high blood glucose level, you can see that glucose is just binding readily to the red blood cells and to the hemoglobin, okay? And that's just a little bit of understanding for what I'll be measuring and talking about for why this is important, okay? And then as I said before, you're gonna see some measures where I talk about blood glucose numbers. To get an understanding, if we want it to be 7 or below, that's just an average blood glucose of 154. Has anyone ever worked with a family member or a patient or a friend who's had a blood glucose level that's above 200 or heard about it, or above 300? And then it gets really scary when it's above 400 and 500, and that's where it's very scary and you need to get to the emergency department. But you can see here, we're not saying you need to be perfect with your blood glucose levels. For those of us who don't have diabetes, if we just ate a snack, our blood glucose levels will not go above 110, or 120. So we're still saying we just need it within a healthy range. So 150, targeting around 150 is somewhat reasonable. And why is that important? Because we want to prevent complications. So diabetes in the United States is the 7th leading cause of death, okay? And it's often underreported because there's another reason most likely that was attributed to that person's death. For example, like a heart attack or a stroke, okay? Those who aren't managing their diabetes and they have the high blood glucose levels are at greater risk for having all these health problems. So many of you have heard before that diabetes is associated with cardiovascular disease, so heart attacks. Okay, it's associated with strokes, all right, much higher risks. Have you guys heard about retinopathy? So diabetes is still the #1 cause of blindness worldwide. And that's because what happens is when you have really high blood glucose levels, think of it this way. Bacteria and viruses love sugar. Okay, so if you have high sugar in your blood, you're going to get more infections. But also if you have a lot of sugar in your blood, it's going to affect cellular structure. It's not, first of all, it's not feeding the cells, so your cells aren't functioning properly, but at the same time, that sugar is also damaging the outside cellular structure. So things get hardened. So for those of you who have ever taken a class in public health or talked about cardiovascular disease, when they're talking about the stiffening of the arteries, having high blood glucose ends up causing that because it stiffens the outer wall so you have less flexibility. So if I had diabetes and I had not been managing for 10 years and I literally just ran from the med school up here, okay, and I wasn't able, and my structure of my arteries in my heart were very, very stiff, and because I literally just ran here and I could be in better shape than I currently am, I could be at risk for having a myocardial infarction or something else like that. Okay, because I'm not giving my body the flexibility of pumping extra because I can say, Laura can say, I literally just ran up here. So there are so many problems. Have you guys ever gone out to Walmart or Kroger and seen an individual here who's had an amputation? Yeah. So I can say that when I was in Boston at the Joslin Diabetes Center, where you get most severe cases of diabetes, I could say in the 5 years that I was there that I probably saw fewer than 5 people with an amputation. My first weekend here, when I went to Walmart, I saw probably 5 people with an amputation. It's very common here. And that has to do with a whole variety of reasons. But if you're not controlling your blood glucose levels and you're damaging cells and you're damaging how you can respond to things, you might not feel if you have an infection. And it's a very common story that you'll hear patients say, well, I was walking around the house and I accidentally stepped on a staple or a tack or a nail, and they didn't know it. And because that's an open wound, which allows bacteria and viruses to come in, if you have a lot of sugar, it's feeding the bacteria. Okay, so then you become with this very horrible infection, and sometimes it's too late by the time they get to a medical provider to intervene. And so the best case scenario for what they do is they do an amputation. So what can we do? What can we do for people? Well, what it's recommended, not only nationally in this region, but also worldwide, it's focusing on behaviors. Okay, so my training is in health behavior. And that's why diabetes not only is a perfect model for studying health behavior, it's also very, very relevant because of the epidemic that's happening. But patients with diabetes, we're talking regular exercise, okay, following meal plans, taking medications, and there are a whole slew of diabetes medications. I can't think of many more conditions that have more medications than diabetes. Attending medical appointments. If you have a complication, that means you have even more medical appointments to attend because you generally have to see specialists. And some other things, like you have to get your eyes checked once a year. You have to check your feet on a daily basis for that reason, in case you have lost sensation in your feet. This is so that you can check to see if there is a wound. And if you do have a wound, you immediately get it treated. Does anyone have an idea how many hours a day? Now there's a study out there that was published by diabetes educators on how many hours a day it takes for someone to manage type 2 diabetes and someone to manage type 1. How many hours would you think it takes to manage type 2 diabetes in one day? 12 hours? What do you guys think? Higher, lower? Just on a given day, how many hours does it take to manage someone's diabetes? 4, 6? So, yeah, so for what they said for type 2, 3 hours, okay? Of course, there's a plus or minus range. But then what do you think about type 1? How many hours? More? More? 6 hours. Isn't that crazy? I can't imagine doing something for 6 hours. I mean, I know I'm supposed to work at least 6 hours, if not more, 8 hours a day. But it's really hard to think that if I have to work an 8-hour day, sometimes longer, then I have another 6 hours to take care of my diabetes, right? There are so many issues. Yes?
When you say manage, what do you mean by manage? Like meal planning?
Yeah, so focusing on, so it is including everything, okay? So these are some of the things that we would be doing no matter what, regardless of having diabetes, like food preparation, okay? So if you are grocery shopping, those are the things that have been factored in and distributed over time. But on average, it's still 3 hours a day. So it's grocery shopping, it's preparing your food, it's cooking your food, it's checking your blood glucose levels, it's taking your medication. Some people have to take insulin for every meal or every snack, okay? And you have to check your blood glucose levels before you take your insulin, okay? And then oftentimes, you'll have to maybe check after the fact and just to make sure you gave enough insulin, or if you gave too much insulin, you want to check so that you're not going too low because you might pass out, okay? So, and then exercising. I mean, as Americans, there are guidelines for us. I mean, do you guys know how many minutes a day we're supposed to exercise? 30 minutes, right? So factoring that in, we're talking about exercise. You still need to manage your stress and sleep. These are all components that factor in. So in some ways, when you said 10 hours, it does, because if you have diabetes, it's 24 hours a day, 7 days a week. And it's going to always be in the back of your mind. And the problem is, recent data shows that half of Americans aren't doing what they're supposed to do with their diabetes, and we're not reaching target. So what that means to me is people in this country, and this is not something unique to the United States, we see this in most countries, are at much greater risk of having these complications, okay? So these complications, not only are they a burden on the healthcare system, okay, they're a burden on individuals, okay? It's a burden on providers. There are so many issues, and because of living in this region and being a part of Appalachia, people are disproportionately affected by this disease because diabetes takes into account all of these other factors, the social determinants of health, okay? So I said that the percentage of Americans with diabetes right now is 9.3%, okay? 11% in the state of Ohio. Well, in this southeastern region of Ohio, we are talking Athens County, Meigs County, Morgan County, Washington County, Perry County, these counties, it's 20 to 80% higher than the national average, right? Vinton County, 17%, okay? And keep in mind, that's based off of national survey data for telephones. So the people who are at greatest risk of having diabetes are those who are most likely to have an income less than $15,000, which means they probably don't have a place to live, or they might not have phone service, or they might not have a phone. Okay, so we're missing a huge portion of the population anyway when we're doing these statistics. So I'm guessing the rate's much higher. And I'm actually doing a study where I'm interviewing providers right now about how many patients they have. And I'm talking any provider who will see a patient. And I hear on average 30 to 50% of their patients have diabetes, if not more. And these are, nurse practitioners, physician assistants, physicians, psychologists, et cetera. So it's very, very high. What's unique to this region is that people here with diabetes also face a lot more barriers. And here are some of the interesting factors that we have found so far with patients. They're more likely to have a delayed diagnosis, meaning I might have diabetes right now, but if I'm from here, it probably won't be discovered for another 3, 5 years, if not 10 years. So what's the problem with that? That goes back to why I gave you that whole little story on blood glucose levels, okay? That means I'm having high blood glucose levels for 5, 10 years, which means I am damaging my body constantly, okay? And the thing about diabetes, until you have one of those complications, you don't feel bad, okay? Especially with type 2. You don't necessarily feel bad, okay? It's not like when you break an arm and you have pain, okay? You will feel bad once you get a complication from your diabetes, or if you start losing your vision. And oftentimes, it's too late to do something about it. And you can delay some of that complications, but once it's started, it's really, really hard to go back, okay? So we have a delayed diagnosis, which is a problem. We also know, I'm sure from all the lectures you guys have been attending this week, we have a shortage in healthcare providers in this region, okay? So there's a lot less access to healthcare. Because patients are not getting access to healthcare, they have a delayed diagnosis, we have more complications, okay? Again, with my story, my first weekend here, seeing 5 people in Walmart with an amputation, whereas I was at a diabetes center where they treat people from all around the world, and I hadn't seen that many amputations my entire time, right? It's very alarming. Patients are also less empowered, okay? And that just means that they don't feel that they have the initiative, or they don't have the confidence to act on behalf of themselves. We see that there's a lot of mental health. So regardless of diabetes, in this region, they have a lot of mental health issues, okay? There are a lot of legal issues. And I'm going to talk about that. One of the interesting components of this program is that we have a lawyer who is staffed providing free legal care to patients with diabetes. So some of the legal issues would be whether or not you can have enough food stamps, whether or not you can be evicted from a house, all right, or get temporary housing, or make sure that you get disability or Social Security benefits. Those are some of the legal issues that I'm talking about. We have really high food insecurity in this region. I don't know if anyone's talked about the food insecurity this week. Okay, so then I don't need to really go into it, but we have a lot of issues. And most of the help that we're providing with this navigation program is emergency food boxes. Of course, there are a lot of financial barriers, right? This is Wealth and Poverty Week. We're focusing more on the poverty, right? Athens County almost has nearly a third below the poverty level. That is extremely high compared to the national average. So we have a lot of financial issues. Diabetes is a really expensive disease, right? Do you guys remember seeing in the news in the fall about the EpiPen and the skyrocketing costs? We're seeing the same thing. It's not getting as much media attention with insulin, but insulin prices are going sky high, okay? And we don't know what the future holds, okay, in terms of our healthcare system, right? We're kind of in a little gray limbo transition period, and we don't need to talk about that, but it's happening. And what concerns me is the cost of medications, okay? So we don't know what will be covered, and some patients need to be on insulin, but insulin is so expensive, okay? There are a lot of housing issues, all right? One thing that I've learned from being on this project, and I've lived in different parts of the country. I was born in Iowa to a town of less than 500 people, so I know rural, okay? But then I've also lived in Boston, so I've seen a variety. And being a part of this study, hearing the stories of what the navigators and the nurses are doing, I didn't realize how many families live in tents in Athens County. And it's very distressing to hear how many children are living in tents. And it's just something that has made me even more dedicated to keep doing what we're doing, and why this is so important, and why we need to focus on diabetes, because again, diabetes is really affecting this region more so than other regions in the country. And then we have a lot of transportation issues. It's rural. We don't have public transportation. We don't have the T like Boston does. The T is the subway. Anyone? Boston? No? Yeah, you're from Boston?
No, I'm
Oh.
not from Boston.
But you've been? Okay. Do you like the Patriots? We won, right? Huh. Probably not Patriots fans here. That's okay. But there are a lot of transportation barriers, okay, because this is a rural area and we don't have public transportation. So there's a colleague of mine who, interestingly enough, is from Boston. Her husband is at the med school, and we did our postdocs together at the Joslin Diabetes Center. And now I'm working with his wife, and that's Dr. Francesca Gordon. And she is with the Voinovich School. And she's doing a lot of statistics, helping with me to identify what are some of the things that we're observing in this population. Because even though diabetes is really affecting this region, it is understudied. Now, I'm sure there are a whole variety of reasons. Maybe we just haven't had as many people interested in studying diabetes here. Maybe it's because people don't want to participate in research studies here. There could be a whole host of reasons, right? But what data we do have nationally, Dr. Gordon is using. And what she's showing here, so you can see with this graphic, is she's looking at, you can see this is the rate of diabetes in the state of Ohio, 11%, okay? And then she broke it down by counties and Appalachian regions. So you have the non-Appalachian right over here. So the non-Appalachian regions, okay, of Ohio are actually below the state average of 11%, which means that the counties of Appalachia are actually bringing up the prevalence rate, okay? And then you look over here. So we're in Southeast, right? That's Athens, Hocking, Meg, Perry County, Washington County, okay. And then you have Southern, which includes Vinton County and other counties. And then you have the East Central, right? Look at the rates. So we're talking close to 13% here on average, all right, compared to the general population of 9%. So we have really, really high rates here. And the thing that gets me is Athens still has a prevalence rate above 11%, which is the state prevalence. Yet we're factoring in university. So these national data statistics are interviewing university students who are going to be much less likely to have diabetes, as well as faculty who are well educated, who make a good income, okay, who are also much less likely. But we still have a very high rate in Athens County. Then you can look here. So she did some analyses looking at education level here, okay, and she's comparing Appalachian versus non-Appalachian. So this is not finishing high school. So those here in the non-Appalachian region actually have a higher rate of diabetes, okay? But then soon as you look at the others, you can see high school graduate, Appalachian regions have higher prevalence of diabetes. A little bit of college, then you see a much bigger difference, okay, in diabetes. And then you also see for those who graduated college, you still have a higher. But what you need to focus on here is that the less education you have, the more likely you are to have diabetes, okay? It's something that you guys are learning here. I'm sure it's focused. You guys have talked about this here throughout the week. It's not a surprise, okay? And then she also broke it down by income level. So the Appalachian regions and the non-Appalachian regions, those who are making less than $15,000 a year, it's 16%, close to 17% of individuals have diabetes. And okay, and then you can see it gets better the more money you make. And as you would make sense, okay, you might have a higher education level, you have better access to resources. You know, money does come in handy, right? But again, if you compare the rate, those making less than 15,000, so those who are below the poverty level, that's almost a 17%, prevalence rate of diabetes. That's just crazy. And then she looked at smoking. So Dr. Gordon had this great idea to look at smoking. And it'll make sense in a few slides for why she ended up looking at this. So she compared it first, by gender, and of course in the Appalachian regions and non-Appalachian. Okay, and what you see in southern Appalachia and southeast Appalachia, we have much higher smoking rates, but particularly with women, okay? So I'll have you guys think about that, and maybe we can open it for discussion, because to me it's very interesting. And this is why you need to have interdisciplinary research, okay? Because I might know stuff about behaviors, but I might not know, for those who are anthropologists and sociologists, I might not know enough about the community where you guys could inform as to why individuals are smoking and why women are smoking more than men. Okay, and then the other thing that we looked at is we looked at depression, okay? So those who have a depression diagnosis are more likely to have a diabetes diagnosis. And this is supported by the literature. And it goes both ways. If you have diabetes, you're more likely to have depression. In fact, you're 2 to 4 times more likely to have depression compared to the general population. And if you have depression, you're more likely to develop diabetes. So it's one of those bidirectional relationships where diabetes and depression go hand in hand, okay? And you can see that depression rates are so much higher in southern and southeastern Appalachia. And this is why I said to hold on for a second. What she ended up doing is she looked at male and female, Appalachian, non-Appalachian, and smoking rates, okay? So you can see by gender, you can see those who are diagnosed with depression are smoking a lot more, okay? And we haven't done the analysis yet, but I bet we're going to find those who are female, who are smoking, who have depression, are also much higher risk of having diabetes and have diabetes, okay? We haven't done the data analysis yet, but that's what we're going to find. So what's going on, right? Maybe we can pose this for conversation at the end, but I haven't seen much. This is some of the first analyses that I've ever seen that really have focused on something like this. And there is some work that does say that a lot of women, or people in general, use smoking as a way of self-medicating, okay? And while people would say, well, it's so expensive to smoke, well, if you buy a large bag of tobacco and roll your own cigarettes, it does not cost as much. Did you have a comment?
Yeah, were these assessed by racial, or did race account for any
So
of this?
these are all controlled for race, age, and unless she's specifically looking at income or education or gender, she's also controlling for all these things. So we're controlling for those factors. The thing about this part of Ohio and Appalachia, what is the percentage of white people here?
97.
It is predominantly white, right? Whereas if you go to other, places where diabetes is more prevalent, if you look, we have the same diabetes rates as the diabetes belt, which is down in the south. Okay, if you're talking about Mississippi, Louisiana, we have the same rates. The thing that differs is by race. So that's a very good question. So that's a lot of background to get me to my point, right? Okay, so diabetes is a global problem, but it's disproportionately affecting this region, okay? And we can see by some of that information, the lower education levels, the lower income levels, okay? All the barriers with lack of transportation, housing, food insecurity, we can see why people are at greater risk of diabetes here. So what do we need to do? We need really good innovative strategies to address this, okay? And we came up with a strategy, and that is this comprehensive patient navigation program. So is anyone familiar with patient navigation or heard about patient navigation? Okay. So it's not new. It's been around for a while. It comes from the Harold Freeman and his research, and it started with cancer. So women who were diagnosed with breast cancer who either weren't getting screenings and needed to be screened or weren't going to their treatment. So what they did is they created this patient navigation program where they focused on the barriers, the social determinants of health, and had these navigators kind of walk the patient through the healthcare system and address some of the barriers. Oh, you don't have transportation? I'm going to get you transportation so you can get to your medical appointments. And they saw a dramatic improvement in terms of lifetime survival and also preventing women getting mammograms and then preventing breast cancer. So what we did, and when I say we, I mean I was fortunate to kind of walk into this role. Has anyone ever met Jane Hamill-Lambert? She was at the medical school. She's no longer there. But she's the creator, the designer of this. She used to work at the medical school. She's now at Nationwide Children's. She's back into pediatric counseling. And she came up with this idea because she's been working in this region for so long. And then Sue Meeks. Does anyone know Sue Meeks? Yeah, Sue's great, right? So this is Sue Meeks and Jane Hamill-Lambert's baby that they came up with. And I was fortunate that right around the time I came here to this institution, they were creating this project and they needed someone who knew something about diabetes. And so I was the diabetes expert here. And so they designed this and I'm providing the content about diabetes and health behavior. But we have a patient navigator, okay? Then we added the medical legal partnership. Has everyone heard of MLP? So it's just focusing on the fact that for medical issues, sometimes there are legal issues, okay? And if we have a lot of these social barriers here and the social determinants of health, it would be really great if we could provide free legal care. And so this grant allows us to have a lawyer on staff to provide free legal care. And then the final component is a consumer engaged coalition. So it's great that me and Jane and Sue and other members of this research team came up with this great model, right? But it's also really important what people living here want. So we created this consumer engaged coalition to hear from patients with diabetes. What are their needs? What do they want? Okay, because if they're not interested in having a navigator, or if they don't want free legal care, that's important for us to know. So what is the goal? We just want to improve health for these patients, okay? You know, technically it's so that we can improve A1Cs, you know, because if we can improve those outcomes, we're more likely to be able to sustain this program because insurance companies will pick it up, okay? And then they will cover costs of having a navigator or a lawyer on the team. Okay, so it always comes back down to money, right, and business. But that's the reason we're so focused on those outcomes such as A1C. But we also want to reduce healthcare expenditures, okay? If we can show that we can reduce healthcare expenditures, again, insurance companies will buy into this, right? So again, we want to improve the A1C. We want to improve blood pressure as well. We want to improve whether or not someone's doing exercise or eating healthfully or taking their blood glucose levels. And then what we're really focused on here too is reducing depressive symptoms and reducing diabetes distress. So diabetes distress is probably a condition that most of you have never heard of. It's relatively new in the literature, but that just means because you have diabetes, you are distressed with living with diabetes, and rightfully so, because that's a distressing condition to have. So we're hoping to reduce distress levels as well as depressive symptoms. These are the things we're measuring, okay? And we also really want to reduce the expenditures, okay? We want to reduce hospital admissions, hospital readmissions, emergency department use, okay? And we want to improve legal outcomes. We want to prevent evictions, okay? We want to provide more food stamps. We want to provide more housing, permanent housing, ideally. So these are the things that we're focusing on legally. And we are looking in terms of outcomes, we are looking at the use of hospital admissions. So we're looking at hospital data as well as some of the legal outcomes. So we created this consortium. Again, this was Sue Meeks and this was Jane Hamill-Lambert. So we have, I'm the evaluator, I do all the analysis. We have the navigator, that's Sue Meeks and Jonna Preston. So Jonna Preston is the nurse who is doing this work where she literally goes out in her car and travels all over the region to the patients to help them. We are affiliated with 5 primary care clinics where primary care physicians can refer to us. We also are affiliated with the Endocrine Center, which is at Castrop, right next to Oblenis, and so that they can also refer to our navigator. We use Southeastern Ohio Legal Services, and we have a lawyer on staff, Ann Rubin. She's very, very dedicated to Appalachia, and she's been working in this region for over 20 years. And so she provides free legal care to anyone who's in need. And then we have this little patient group. And so again, this is just the specific partners that we have. So what is a navigator? I kind of explained it a little bit, but it's someone who just helps a patient navigate through the system, right? I work at a medical school and I have education in health and medicine, yet I sometimes struggle with navigating through the medical system. So I can't imagine for someone who's been as fortunate as me to be trained and have a job that if I struggle, I can only imagine for someone who doesn't have the opportunities that I've had, okay? So a navigator helps a patient walk them through, explain what's happening, explain why they're being referred or why they have to stay in the hospital or why they're given this new medication when the other medication they were on was working so well, okay? They can also connect patients to social services and benefits. So we were fortunate, based off of our first year, one of the things that we found is the mental health need for these patients. So there is Ohio University has our psychology and social work clinic. And so Chantel Weisenmuller runs that clinic. She is now once a week coming to the Diabetes Endocrine Center and seeing any patient in need. So we have the staff at the Endocrine Center, those patients who have expressed, you know, that they are depressed or anxious or really struggling. There are 2 to 4 hours a week where Chantel, and then she brings students with her, And they're there on site to do an intake, and then they provide free counseling, okay? And we are just so lucky that that clinic is doing that. And it's really, we're going to collect data as we go on so that we can demonstrate the need, because we want to sustain these services. Right now the grant's sustaining us, but grant money is not a permanent fix. But the goal of this is not only to help the patient, but we also want to empower patients to start taking action on behalf of themselves. So what do? Well, we can explain medical information. So Sue Meeks is very much a believer in having a nurse be a navigator, okay? Now, I am of a different mindset. I think a community health worker would be great. I think a social worker would be great. I want anyone who's dedicated to helping. But Sue runs a family navigator program that's nurses, okay? And her reasoning for that is because a nurse has the medical background to explain some of the information that's happening to the patient who has diabetes. Okay, so there's a lot of value in that. So Sue Meeks is a nurse, and Jonna Preston is a registered nurse. They can help access benefits. Some of the things that I'm talking about, food stamps, getting additional insurance coverage, a lot of these things, they provide, and the biggest thing is the navigator provides support, right? And bless Jonna's heart, because Jonna will text or have phone calls with the same patients for 2 to 3 hours every day. And because that's what these patients need. They need someone to show that someone cares about them. So here's just a little vignette that I'm going to share. So RH is a 76-year-old woman with type 2. She has a fasting glucose of 227. Okay, so just knowing that she has a fasting glucose that high means her diabetes is not well controlled. She has a BMI of 38, so she's technically morbidly obese. She has high triglycerides and a history of neuropathy. And neuropathy means she's losing sensation in her fingers and her feet. She wants to enroll in Medicare Part D, but she has to pay a large penalty. Currently, she's paying for all of her medications out of pocket because she doesn't have Medicare Part D. She has applied for a medical card 3 times, and she's been denied each time. She's also struggling with her diabetes diet and feels isolated because she doesn't have any social support at home. She's applied for the Payment Percentage Income Payment Plan, which is referred to as PIP. I prefer the abbreviations. The Home Energy Assistance Program, which is HEAP, and the Cincy Smile, so she can have dental care at affordable costs. And then she's having difficulty paying for hospital bills because she's having these complications. She's had to go to the hospital, so she's applied for Hospital Care Assistance Program, or HCAP. This is what Jonna was able to do for this patient. She increased her food stamp assistance from $16 a month to $169. She got her enrolled in Social Security Extra Help that provides Medicare Part D at no cost. Her monthly medications are now $7 for each medication, which is now saving her $800 a month. She enrolled her in HCAPs, so she's covering the hospital bills. She got 100% discount on all of her medical bills from 3 different agencies, saving the patient $300. And now the patient has been feeling more empowered to take care of her diabetes, so she's increased her physical activity. She has lowered her A1C to 0.4%. And research is showing if she can get it down to 0.5%, she can dramatically reduce her risk of having a complication. She's decreased her triglycerides, and she's improved her cholesterol. So I don't have the data in numbers to show how successful this is, because I can tell, I keep looking at the social workers, because I'm sure you know how labor intensive it is to have a case. And so she has an active caseload of about 30 to 35 patients, okay? And we have had patients who are on her caseload for 9 months, 12 months. So we've only seen 57 people in year 1, which, if anyone do statistics, that's not really enough people to show a difference, okay? But we can show right now, qualitatively, that we're making an impact. And then here's another vignette. TW is a 65-year-old man with type 2 diabetes. He has an A1C of 8.8. So again, he's not well controlled. He has a chronic foot complication for 2 years. So he has a wound that will not heal. He has multiple hospital bills totaling $8,000. He requires a partial amputation of the left foot. But his surgery was canceled due to a change in his insurance, and now it's not covered, so he has to pay out of pocket. Okay? And we can all guess that having an amputation and a major surgery like that is going to cost thousands, right? To pay out of pocket, that's unreasonable for most people. This is what Jonna was able to do. She reduced the hospital bills from $8,000 to $300. His additional bills were approved for a 75% discount. She enrolled him in HCAPS, which is the Hospital Assistant Program. He's receiving medical care at a reduced cost now. He now sees a podiatrist in Columbus to help with the chronic wound. He's had no hospitalizations, no emergency department visits, and no medication changes, which are all viewed as very positive things. And right now they're controlling the wound, and we're going to see if he needs to actually have a surgery or not. So these are just 2 cases to see that she's making a huge difference. So the medical legal partnership, okay, Ann Rubin, who's been servicing this community for over 20 years, we recognize that health can be associated with legal outcomes, okay, like the evictions, the transportation and housing. How can you take care of your diabetes by focusing on what you have to eat or exercising if you don't have a place to live tonight? Or if you don't have food, and how can you take care of your diabetes if you don't know where your next meal is going to come from? Or if you have a child, you're going to put the child first, okay? So this is where Ann can step in and make changes. So we follow the iHelp, okay? So she follows the medical legal partnership. We're providing income and supports, housing and utilities, looking at employment so that people are not wrongfully fired. Legal status is an issue that she looks into, and then also personal and family stability. Okay, there are a lot of child services situations. A lot of times there are patients who are married and really want to get divorced, but they can't afford to. So there are a lot of these issues that Ann's able to help with. So here's the vignette that she gave me. JB with type 2 diabetes is in her late 50s and referred for legal assistance. She's afraid she's going to lose her job because of her diabetes. So she wants to know her insured Social Security benefits and when she can retire and if she can apply for a disability. So the lawyer informs her that there are rules for Social Security in Ohio Public Employees Retirement System, which is OPERS. She helps her understand that she has rights as an employee and tells her to ask for an employee handbook. Okay? And so what it is this person works a cash register. Okay? But one of the diabetes medications that she's put on causes a lot of gastrointestinal problems. So if anybody knows anything about diabetes medications, there are a lot of nasty side effects at times. And so if she's working a cash register but feels the need to immediately run away to go to the bathroom, she's afraid because her boss has been warning her that she can't do that. So she's afraid that she's going to get fired. And what Ann was able to do is to give her the information that she can empower herself and that there are rules. And she says that if she is fired, there is a case for unemployment. Okay? And Ann would then lead up that case. So it's kind of providing reassurance to that patient as well. And then finally, this community coalition. Okay? This is where we're getting community members who have diabetes, and one of our co-leaders, who also happens to be a navigator, has diabetes. So our leadership has diabetes as well as those community members. And this is, we need communities. We need to hear, I am not from here. Okay? I may be able to relate from being from a rural town in Iowa, but that's also very different than being in a rural town in Ohio, right? So I'm an outsider. So we need to hear from people here what they need rather than me thinking of what I think they need. So we created this group. It's called Diabetes Community Partners. And what's great is our little group of community members helped design this with the graphic artist from the university. And you can see here, these are supposed to be people who are all holding hands. And one of the universal symbols for diabetes is the red blood drop. Okay, so it's these 3 people working together. And they created their own vision statement and mission. This is, of course, with the help of some individuals at the Diabetes Institute. And the vision is better diabetes management through better choices. And the mission is to use professional partnerships to instill hope for people with diabetes, equipping them to make better choices through a sustainable peer mentoring program utilizing trained mentors. So what the community group came up with is they wanted a peer mentoring program. So they didn't want us to have referrals to go out necessarily to a diabetes educator or to a physician who's going to tell them what to do. They wanted someone who has diabetes, who's doing well, to then show them the way, right? So a social support system, but also a peer mentorship program. And we successfully completed the peer mentorship training. And February, which is this month, is when we first started our mentor-mentee relationship. So we are just starting that now. Here's a picture of our leader, as well as we have 5 core members of our consortium right now, or the coalition. And this was at our expo, if anyone happened to go to the Diabetes Expo. So these are our members. So if you guys know anybody in the community who would like this opportunity, please let me know, because they're really excited and they can't wait to start mentoring people with diabetes in the community. This is the little vignette from one of our community members. So MS has had type 2 diabetes, and she's participated in nearly all of the diabetes education and support programs available in Athens. She joined the Consumer Coalition to help keep myself on track, and she's been instrumental in the success of the first year. She's one of the first to offer support to other coalition members and learn from their experiences. the Consumer Coalition has discussed at length the barriers that people living with diabetes experience and what resources are available to help them overcome these barriers. This group helps me, and I want to be able to help other people too. People just don't know what is out there to help them. So she sees herself as, I've been able and fortunate enough to take advantage of the resources, and now it's her turn to pay it forward. So what have I learned here? It's going to be a slow process, but it's working, right? And maybe I'm not going to see improvements with everybody with their A1C right away, because that takes time. So if we can get someone from temporary housing to permanent housing, okay, we're not going to see in 2 months an improvement in A1C because they've been worried about getting housing. So we're not going to see that change yet, but if we can see maybe a year from now, okay? Now the problem with that is when you report back to a granting agency, they want measures right away. So I'm going to have to get really creative in what I can present to them to show them that this is really working and making a difference. And so what I'm hoping is that we're really going to see improvement in depression and distress, okay? And then if I can show that the high rates of depression, okay, exacerbate diabetes and the poor blood glucose control, then I can make the argument, if you give me a little bit more time, we'll see the improvements in the A1C. So that's what we're hoping. So we're going to keep doing this, okay? And then hope we're able to sustain this. We're showing that this is working, and navigation has been shown to work for a lot of different health issues, okay? And cancer is being the one that's most well-researched. But this is one of the few programs that's using diabetes for navigation. But it's working. And now we have this legal partnership, and it's working. So I hope you're able to get something from this to show that poverty is affecting this region. But it's really important to look at health too, okay? And health is not literally what is your A1C level. Health is how do you feel and what's your quality of life, okay? And so if we can do things that address the health as well as some of the barriers based off of poverty, then we're making a difference. And, okay, I can't forget, I get to talk here, so it looks like I'm, the person who's doing all this stuff, but it's because of this great team. Again, Jane Hamill-Lambert, who's now at Ohio State Nationwide Children's, she's the designer, she's the creator. Sue Meeks, some of you guys know, I don't know, she's the savior. She's a wonderful person. She's been doing navigation for a very long time. I don't know if you guys have heard about the MOMS program that she's done, and she's helping pregnant women in this region who the women are addicted to opioids, and she's helping the women get off opioids and then also helping the children. John Preston's the navigator who's doing all the hard work. Ann Rubin's our lawyer who's providing all the free legal care. Carrie Cook and Kristen Kerwin are the 2 registered nurses who are in charge of the coalition. Stacy Wright is at the Endocrine Center, and she helps us with the referral system. She helps organize things for us, so she's been invaluable. Missy Stanley is probably one of my favorite people in the world because whenever I don't have an answer to something, she always does. So she's the director of operations of the Diabetes Institute. But I'm kind of new to managing a large federal grant, and she has all the answers, and then she, when I feel like jumping off the ledge, she says, no, it's okay, I'll fix your budget. So she's wonderful. And then Francesca Gordon, who started doing all these analyses here with some of the national data that we have so we can really look at what's happening in this region. So again, it's never just one person, it's a whole team. And thank you guys for letting me be here and talk to you. I really appreciate it. So thank you. And if any questions? Yes?
The patient navigator, is that an employee of the hospital or the clinic or from a separate organization?
So that's a really good question. Because this is a grant, we did it through the medical school. So this is an employee at the medical school. What we're hoping is if we can show that this works, we're then hoping that we can have it be over at either O'Bleness. There's going to be a merger with the Endocrine Center. We're going to merge with Ohio Health, which is a really big organization in the state of Ohio. If we can show that a navigator is necessary, then organizations like Ohio Health will hire and be employed there. Yeah. So, thank you very much.